Professor Khami, can we start now?
Yes, sure.
Okay. Professor Shamshiri, please, we hear you.
Thank you. Hi again. My last presentation is about critical appraisal of cross-sectional and other observational studies, I mean analytical studies. Here I again introduce observational analytical study designs and introduce some critical appraisal tools and review one of them and show you the items important for critical appraisal of cross-sectional studies, cohort studies, and case control studies. In category of observational studies, there are three main analytic study designs named cross-sectional, case control, and cohort studies. In analytical studies, we try to investigate the association between at least two variables, here X and Y. We name X as exposure variable, independent variable, in some cases maybe a risk factor, predictive factors as prognostic factors, or also maybe an intervention in clinical trials, for example. And the Y, which stands for outcome variable, dependent variable, in some cases disease, and endpoints and events. There are different nomenclature of these two variables. Here, the X affect Y, and Y is affected by X. And in analytic study, we investigate their relationship under a study hypothesis. In cross-sectional studies, we have a defined population and we get our study samples by a defined eligibility criteria. And in one time, as a snapshot, we ask about both exposure and outcome in one time. For example, today, do you have any exposure to smoke? And today, do you have any disease? So this is the type of question in a cross-sectional study. Today, do you have any exposure to a risk factor? And today, do you have involved or suffer from a specific disease or not? And we categorize the population or participants to four categories: exposed with disease, exposed without disease, unexposed with disease, and unexposed without disease. And then perform a statistical analysis to investigate the relationship between exposure and outcome. In case control studies, we start from the outcome variable. I mean the end of the association, end of the relationship between exposure and outcome. So the direction of the study is from the outcome to the exposure. Here we have two groups, one group with outcome and one group without outcome. And as I said before, the outcome mainly is a disease. So a diseased group and a healthy or a group without the disease in the study. This is 2 groups, and we asked them the exposure to the risk factor in their history. So the question is, do you a smoker, for example, in 2 years before your disease diagnosis or not? Okay. So again, the direction of a study is from the outcome to the exposure. The next study, now just look at the left of the slide. For the cohort studies, we have a defined population which is non-randomly or naturally divided to a group of exposed and non-exposed population, and the investigator follow up these 2 groups and measure or investigate the outcome related to the exposure in future. The direction of the study in cohort studies is from the exposure to the outcome. And because the investigator goes through the events on time with the participants, it's more reliable than cross-sectional studies and case control studies. So always consider the direction of exposure to the outcome, which is also you can see in the randomized control trial from exposure to the outcome is better than the cross-sectional studies and case control studies. Here I provide you 3 types of cohort studies. One of them is historical cohort studies, sometimes named retrospective. It means that the researcher gets the exposure history and outcomes from the patient's records. So there are some databases for exposures and outcomes in, for example, a registry or in a large population cohort study, and the investigator, without seeing the participants, only get the data from the database and analyze the relationship between exposure and outcome. Here, the researcher have no control on the exposure measurement and outcome measurement. So the definition of exposure and outcome is held by the registry or another study who collect the data. So it's the evidence provided with historical cohort studies is the lowest one. The next one is concurrent cohort studies, or sometimes they said prospective cohort studies, which after starting the study, the participants gradually evaluated and eligible participants enrolled in the study, and the measurement of exposure held by the researcher, and then followed for a specific time and measured their outcomes by the researcher. So all data are valid by the definitions provided by the researcher. So it's the best result of the cohort studies. but it's very expensive and needs time to perform and finish the study. So there are some designs to convince and make them cost effective for the researcher. We name them mixed cohort studies. In some cases, you have patients in the databases, and you know that some of them get, for example, treatment A, and some get treatment B. And after, meanwhile, you contact with patients and ask them to come to the clinic for example, some examinations to investigate the failure of treatment or some new diseases. So the exposure is recorded previously with others, and the researcher investigates the outcome himself or herself. So the data or evidences provided by mixed cohort studies is something between historical cohort studies and concurrent cohort studies. Here a list of some of critical appraisal checklists for observational studies. Here you can see Robbins checklist, different checklists, i.e. Newcastle Ottawa scale checklist, IHE, JBI, and other checklists that you can use for critical appraisal. The number of items each checklist have is different. For example, I choose here CEBMA have checklists with 12 items, and here JBI for each study have different items, and I select JBI for a presentation to you. Here is a checklist with 8 items for cross-sectional studies. For each item, we have 4 options: yes, no, unclear, and not applicable. So you can quantify the scale of validation for each study. For example, you can provide 1 if it is yes, or 0 if it is no. And for unclear, you should decide it. Most of the cases, unclear is equal to no. And not applicable means that this study, this item for this study is not applicable. So you can omit this item for that study. The first item for cross-sectional studies is where the criteria for inclusion in the sample clearly defined. It means eligibility criteria. So if there are numerous or frequent items for inclusion and exclusion of the participants, the participants became very similar to each other. We say that the study population is homogeneous. Homogeneous sample size provide a great internal validity for the study, but decrease the generalizability. So if your patient which you want decide for a specific treatment for him or her if the characteristics of the patient included in the criteria of eligibility of this study, the results of this study may be relevant to your patient. Otherwise, if your patient's characteristics is not included in the study, so the results of this study may be not appropriate for your patient. The second question, were the study subjects and the setting described in details? It's again about the subject and settings. As I mentioned before, for example, in office, patients who refer to clinic or hospital or otherwise. And the third one was the exposure measured in a valid and reliable way. So it's something for calibration, considering sensitivity and specificity of the measurement. Is it an objective of the next one? Were objective standard criteria used for measurement of the condition? Is it objective or subjective? Is it acceptable for the scientist or not? It should be investigated thoroughly in the paper. The fifth is, were confounding factors identified? As you may know, the confounders is a challenging item in the epidemiology. Some of epidemiologists considered confounders as errors, and some of them consider confounders as a separate entity. So, and in some cases, there are overlap between confounders and biases, mainly selection bias. So in case of confounding, the author or investigators should consider all variables that affect the relationship between the risk factor and disease. The causal network should be complete. For example, if in a study they only provide or assess the relationship between, for example, brushing and dental decay or DMFD, and ignore other factors that could affect DMFD, the study is not complete. They should also consider, for example, flossing, routine dental visits, socioeconomic status, and other factors, varnish fluoride therapy, to make the relationship between brushing and DMFD clearly and specifically. If the confounders didn't consider it in the study, the relationship between the exposure and outcome almost always confounded by those variables that not considered in the study. So confounding is very important. And after considering the confounders, the sixth question is, were strategies to deal with confounding factors stated? Because we have some strategies to eliminate the effect of confounding from the relationship in consideration. For example, some statistical methods we can use to eliminate confounder, or some methods we use in the methodology, which is more applicable for case control studies and cohorts, for example, matching design, or in clinical trials such as randomization. Next question, were the outcomes measured in a valid and reliable way? Again, as exposure measurement is important, always outcome also is important. And the last question is, was appropriate statistical analysis used? And after answering to these questions, you can decide to include the study as evidence for your practice or not. A similar checklist provided by JBI for case control studies. It has 10 items. First two questions are related to selection bias. The first one, were the groups comparable other than the presence of disease in cases or the absence of disease in controls? So for example, in some cases, early stages of disease could not be diagnosed, and we could put the patient in a control group by mistake. So the definitions are very important. Where cases and controls matched appropriately, here matching is defined by JBI that if you get cases from hospital, you should get controls from hospital. And if you get patients from population, you should get the controls again from the population. So it points to the base of the population. Hospital case, control, hospital controls. Office case, office controls. Population cases, population controls. Otherwise, the study should be interfered with the selection bias. There are 4 questions, 3, 4, 5, and 8. All of them points information bias or measurement bias. The third question asks about were the same criteria used for identification of cases and controls. The next one, was exposure measured in a standard and valid and reliable way? The fifth question, was exposure measured in the same way for cases and controls? It's very important that we use, or the researcher used a consistent method for both groups. And eighth question is, were outcomes assessed in a standard, valid, and reliable way for cases and controls? The sixth and seventh question are pointed to the confounding factors. Were confounding factors identified, which I mentioned before, as I mentioned before, it's related to causal network, and is related to the literature reviews and the researcher expertise in that field to consider all effective variables on outcome as a potential confounders, and where strategies to deal with confounding factors is stated. And last questions, which are very important. Ninth question is, was the exposure period of interest long enough to be meaningful? For example, when we ask about the exposure from the patients and controls in the past, if we go long to past, we interfere with recall bias. The patients and controls could not remember very precisely the exposures. However, recent exposures may not have related to the disease, because we should consider a minimum a period of time between exposure and outcome, and it should be considerably greater than induction period, and it should be considered. And last, again, is about the statistical analysis. So a question, which one is the most important item in case control studies? Appropriate control group or duration of follow-up? Which one is the most important? Of course, all of them important. So which one is the most one? Good, great. Exactly. The most important is selection of control group. Yeah. The weak point of the case controls are the controls. If the researcher take mistake to get appropriate control, the association between exposure and control maybe became underestimated or overestimated. Consider that, for example, a researcher wants to show the relationship between smoking and oral SCC. Smoking and oral SCC. So in a cancer hospital, we have some oral cancer patients. We ask them about the history of smoking. And when we want to select a control group from the same hospital, if we select, for example, patients with lung cancer, which we know that the lung cancers are also related to the smoking, so in these two groups, smoking is high. So the relationship between smoking and oral SCC became underestimated. We should select a group as a control that the smoking frequency is similar to the population. Then the relationship between smoking and oral SCC became fair and real. Almost the last slide is about the critical appraisal items for cohort studies. The item 1, the first item, and the 6 are related to selection bias, where the two groups similar and recruited from the same population. The 6th question, were the groups and participants free of the outcome at the start of the study? Because we said in cohort study, the direction of a study is from exposure to the outcome. So all of the participants should be disease-free in the start of the study. Items 2, 3, 7, and 8, again, is related to the information bias and measurement of the variables. 4 and 5 is related to the confounders and the methods for eliminating the effect of confounders. 9 and 10 is new, as important for cohort studies. Was follow-up complete? And if not, were the reasons to loss to follow-up described and explored? Were strategies to address incomplete follow-up utilized? So as you see, follow-up is very important and critical for cohort studies. If follow-up of the study is incomplete, for example, if the researcher started with, for example, 500 participants and end with 400 participants, and through the follow-up, 100 lost to follow-up, So the composition or the characteristics of the 400 participants at the end of a study may not similar to the 500 participants at the beginning of the study. So the loss to follow-up itself is a type of selection bias. So be careful about the loss to follow-up, and it's completely different from the sample size. So if the researcher, for example, starts with greater number of sample size to finish the study with 500 participants, it's again these 500 participants are deviated from the characteristics of those participants at the beginning of the study. So here, divide these two entities. The sample size only related to the random error, and loss to follow-up is related to the selection bias. So it's not important with which number you start. If you have loss to follow-up in the study, so the final results, it's potentially affected by the selection bias. And the last item is again about the appropriateness of statistical analysis. Okay, the last question. Which one is the most important item in cohort studies? Loss to follow-up or duration of follow-up? Great. Again, both of them are important, and the loss to follow up is more important. Yeah. Thank you very much. It's my references for this presentation. And I'm waiting your questions, if any.
Thank you, Professor Shamshiri. It was very informative and useful for us, and I'm sure it is about for participants as well. Some question during your presentation was written in the chat box. Do you want me to read by one to answer them?
Yes, of course.
I start from the last question from Dr. Pakdaman. Dr. Pakdaman asked that whether bias is addressed or bias refounded.
Oh, good question. The researchers should address the bias. So it's very important. There are differences between those researchers who address the bias and those who do not care about the bias. Again, I point to the discussion session of the section of the articles, which should be provided by the authors about the limitations and strengths. The limitations, it's very important, and it should be mentioned by the author, and it's we can rely to those studies who honestly said their limitations and strengths. And we should seek about the biases in the study ourselves. So both of them are important, yes.
So during the critical appraisal of, for example, of a literature, we should search about whether the bias has been addressed or not.
Yeah, of course.
Okay. And another question was that the difference between historical cohort and case control.
Okay. And case control and historical cohort, as I mentioned, the direction of the studies are different. For case control is from outcome to exposure, so the investigator gets one diseased group and one healthy group and investigate the exposure in past. And for historical cohort, the direction is from exposure to outcomes. So as it is a historical, from their patients' records, they provide two groups, high-risk group and low-risk group, exposed group or unexposed group. And in the records, they seek about the outcomes. So two groups are not diseased and healthy. In historical cohorts, the study groups are exposed and unexposed. It's the difference between these two designs.
So one of them is about the exposure, the other one is about the outcome.
Yeah, yeah.
Okay. And the other question was that is case control study is a cross-sectional study?
Actually not.
No.
But in some cases, the exposure and we have different exposures, and how the questions presented and asked from the participants is important. If they ask the exposure in one time, so it's cross-sectional. If they ask the exposure from the past history, it's became a case control.
Would you please repeat again? I didn't understand it.
Oh, okay. For example, if you ask the patients, are you smoke cigarette today? The answer used for cross-sectional studies. But if you ask the smoking in the previous year, and you want to relate the previous exposure to the outcome from this year, it's became a case control study.
Okay, thank you. And the first question was one of the participants asked, and I think it was answered, but if it is not clear yet for you, the audience that asked this question, an example of critical appraisal. Professor Shamshiri during these presentations gave us different samples of critical appraisal. I think it is clear now for you. If the audience that had these questions, any other question, please write in the chat box or ask this question. It is my question that I asked now. Is it possible to ask the question now?
Of course.
Yeah. For the cohort non-randomized study, that there is a group of exposed, another group is unexposed. Is it ethical?
Yeah, difficult question. Why it's not ethical?
Because in intentionally we choose two groups that one of them, for example, has been exposed, exposed to a medication, and the other group intentionally doesn't give the medication.
Good.
Because it will have an effect on the health of the patient.
You're right. But non-random, it's not that we intentionally give the intervention to one patient and intentionally omit or withdraw the intervention from the others. Consider, I think you interested with COVID.
No, it's a question in my mind that whether it is ethical or not.
But I have a good example for COVID treatment. One of the strategies for treatment of COVID is plasma therapy, convalescent plasma therapy. Plasma from the cured patients to the critical ill patients. As you know, in first days, the donors of plasma very limited, and few patients come to donor their plasma. So when we have plasma for patients, we give the patients the plasma. In other days, when we have no plasma for therapy, the patients treated with other treatments. So in this case, there is no randomization, and
Okay.
it's not ethical.
Okay. Yes. So we do not randomly, intentionally select the patient, and because of that reason, it is ethical.
Yeah, of course.
Okay. There was another question, I think it was from Dr. Mustafavi about in vitro study. Let me, um, oh, I'm sorry. I cannot read it. Dr. Azam Mustafavi asked about the in vitro studies that Dr. Lady has asked that since many in vitro studies are performed in the field of dentistry, which scale or checklist do you propose for appraising them for the in vitro study? Which checklist do you use for appraising them?
I think I have provided a checklist for in vitro or experimental studies, I think so.
Okay, by this way, there is a checklist for appraising the in vitro studies as well.
Yes, of course.
Okay.
Also, we have checklists to appraise expert opinions. Yeah. So for experimental, of course, we have. Yes.
Okay. So, do you have? Can you introduce the name of some of them?
I will write it in the chat box for you.
Okay. And again, Dr. One of the audiences asked, sometimes in cross-sectional study, we ask about the duration of time in the past, like past year. So it is cross-sectional study or case control study?
Okay.
It is the last question.
It's an advanced question because in some cases we have a mixture of cross-sectional and, for example, case control studies. Some of the variables or risk factors we ask, for example, such as gender, it's not for present, it's for past. Okay, and some variables are just for present, not past. So there is a mixture of the variables and risk factors, and we should careful about the interpretation of the results. You're right. So for these cases, it's not important what's the name of the design. You should focus on how the variables measured.
And another question is that which is ideal scale or checklist, which is ideal scale or checklist for doing critical appraisal for all studies? I think the audience asked, would you recommend any checklist that is much better than the others that we can trust on?
No, of course not. It depends on the field you study for that. In some cases, we ought to make own checklist when we, for example, run a systematic review. We get some questions from this checklist and from that checklist, and maybe we add some questions because the importance of that point in the field.
During your explanation and presentation, you mentioned the point that for each type of a study, there's a definitive type of checklist, so we should refer to them. Is it right?
Yes, of course. Yeah, for example,
Yes.
CAS
So it depends on the
different.
study.
Yeah, of course.
It depends on the study. And another question, design of a study is cross-sectional, but we add history. Do you understand this question to answer this audience?
Again,
Zahra Saeed Muallemi asked this question.
Design of a study is cross-section, but we ask history. I think it's mentioned by another participant. Yeah, don't think about the name of design. Only focus how the variables are measured. Some of them may
That's
be
right.
measured from the past, and some of them may be measured from present. The validity
That's
of
right.
measurement is more important than the design itself.
That's right. It depends on the time. It depends on the whether we evaluate the outcome. It depends on whether we evaluate the exposure. So all of these factors can clarify that what is the design of a study. This case control studies, historical cohort studies. So according to definition of Professor Shamsuri, we can define them and categorize them and classify them. Is there any question else? So apparently there is no questions. Professor Khami, do you recommend anything? Please let us know, please.
Okay, thank you. Thank you, Dr. Shamshiri, for his, I think, very nice presentation, and I think very good discussions about these observational studies, case control cohorts, historical cohorts, and so on was done. So if still there is any question, just the participants can write down in the chat box, and we will have time at the end of the presentation. Is there any problem with my voice?